biologic addressing TSH receptors or EGF-1 has led more or less to the same result. And why that? Because they can block the start, the culprit antigen which act in activating T helper and macrophages, but they cannot block intermediate chemotactic gradient activated by the same cytokines. And it is so that recently, well, 5 years ago, it was published a paper where more or less the same result of 2 millimeters, 3 millimeters were obtained. Still quite disappointing, but this time the 2 millimeter was judged by the Food and Drug Administration as an effective treatment for Graves' orbitopathy. What has changed, I don't know, but it is so. Of course, Graves' orbitopathy patients have much more than exophthalmos, but also if they had only exophthalmos, 2 millimeter could be really a little bit, because what could be 2 millimeter for this patient with corneal exposure? Probably nothing. It is so that I keep applying my own medicine, the so-called Leliobimab. But it could be also an Augustocimab or Ashok Gmab or Ganga S-Mab. It could be also Bob K-Mab or Andrea K-Mab. And I favorite these two last names because K, that is in between, give you an idea that orbital decompression is the right choice for the moment being. So again, we have to apply to many patients of us, let's say Andrea or Bob K-Mab. This is, for instance, last patient I operated last week. That was at surgery on Thursday, and this photograph was Saturday morning when I sent him home. This is another patient. Again, one single dose of our, let's say, drug can lead to this result. 2 millimeters here is not sufficient, but speak seriously. Surgical therapy is still, and I say still, the mainstay way to reduce exophthalmos. We are a bit primitive because what we are doing is exactly the same what in the Ande or in the Italian Apennine 17,000 years ago primitive men were doing to evacuate, let's say, demon from the head of the patient. So madness was treated with this surgery, not indicated, but still they were doing more or less what we are doing right now with orbital decompression. The typical signs and symptoms are due to swelling of the orbital tissue in the presence of a not extensive bony orbit. And it is obvious that every procedure aimed at decreasing the intraorbital pressure, it named as decompression, can reduce exophthalmos and its effect. It has also the negative effect of displacing the visual axis. For this reason, surgery has to follow orbital decompression. And since the position of the eye, particularly when there is vertical strabismus, adversely interfere or impact the position of the eyelid, you have to do eyelid lengthening following orbital, let's say, strabismus surgery. Finally, functional eyelid surgery with blepharospasm and aesthetic eyelid surgery can be done. So, in summary, the sequence of rehabilitation has to follow this line, as the preceding procedure can influence the extension and the necessity of the steps that follows. Through the years, fat has been removed exactly like bone has been removed. And this has been done through several periorbital or distal incisions. The current indications are in the early phase of the disease, when the compression can be used to cure optic neuropathy for compression, as you see on your right-hand side, or stretching, left-hand side, when steroids fail to cure the problem. Or exposure keratopathy, again, can be treated with orbital decompression. Early choroidal falls can respond to orbital decompression. In the subsequent stable phase of the disease, orbital surgery can be applied for aesthetic rehabilitation and also for reducing the retroocular pressure, like you can see on your right-hand side, in patients where there is an incredible retroocular tension that make their life very complicated. When orbital decompression has to be done in this phase, it was recommended to do that as early as 6 months to avoid fibrotic, let's say, orbitopathy. In reality, in this paper, we demonstrated that up to 9 years following the stabilization of the orbitopathy in a large number of patients, the results were equal to patients operated within 2 years from the beginning of their disease. The same applied to radiotherapy. It was recommended some years ago not to apply radiotherapy because fibrosis could adversely interfere with the effect of decompression surgery. It was also not true, and it was demonstrated in this large retrospective series. Well, able subluxation is also another indication for orbital decompression surgery, and it has to be applied anytime during the course of the disease, as able subluxation is a possible reason of corneal damage and optic neuropathy. Postural visual obscuration can also respond to orbital decompression surgery, particularly in those patients with diabetes or hypertension, where they have, let's say, suboptimal, let's say, circulation and suboptimal patency of their vasculature of the optic nerve. So, in summary, indications for orbital decompression are functional, aesthetic, psychosocial, and symptomatic. Well, some historical notes, actually. The roof is not used practically anymore because it contributes minimally to orbital decompression. The compartments that are addressed nowadays are the medial wall, the floor, the lateral wall, and the two inferior fat compartments. In the States, it's preferred to address the lateral wall first, while in Europe, Eugogo have shown that the inferomedial decompression is still the most frequently used technique, and the lateral wall is used only in the most severe case, like in this case. But why the lateral wall is so important? The lateral wall is just behind the eyeball, and also in the presence of fibrotic orbit can contribute to a direct one-to-one decompression, while inferomedial is an indirect decompression, where the orbital contents shift medially and inferiorly, and consequently the eye go into the orbit. So direct versus indirect decompression. In a study that we did in Amsterdam, we showed that the lateral wall decompression has a huge variability in its result, and this reflects the great inter-individual variability of this bony space. So please use the lateral wall when the lateral wall, deep lateral wall, is thick. Don't use the lateral wall when the lateral wall is thin, because you don't obtain that much. So again, customization passes through a careful evaluation of the bony orbit. The inferomedial decompression is quite rewarding in terms of result. And lateral inferior orbital fat compartment can also be addressed together with the medial inferior fat compartment. This can be done not through a direct incision, like you can see here, that leave visible scar. It can easily be done through the inferior fornix without any incision on the skin, and through this route you can remove widely the floor, leaving the infraorbital nerve as a bridge there, as you can see, and then you can reposition your tissue without one single stitch, still sparing money for your hospital, because at the end it's costless, this operation. Through this route you can remove widely the floor from the inferior orbital tissue up till the frontoethmoidal suture, and you can also remove the body of the sphenoid in a way to implement your decompression effect. This is the result one day after surgery. Since you don't dissect the eyelid is dissected en bloc. There is no virtual space where liquid can accumulate And for this reason, the rehabilitation is extremely rapid without any hematoma around the eye. This is another patient. This is another patient, particularly indicated in blacks, because it doesn't leave any scar, and as you know, blacks are prone to develop keloid. Some white also develop keloid, but at a minor rate. So, as you can see here, the result is quite attractive. Simultaneously, you obtain reduction of exophthalmos, lengthening of the lower lid, and also you repristinate a proper drainage of the venous system of the face, so the puffiness is reduced. So not only you address the eye, but you readdress the mid-face and the lower face with the same. In the case you want to implement the lengthening of the lower lid, you can insert some sclera or artificial material or hard palate mucosa, simultaneously performing a lengthening of the lower lid with attractive result as this one. You might also remove herniation of the fat, doing in fact a decompression and a blepharoplasty. In this case, of course, the bruising the day after surgery is more prominent, as you can see here. You can remove widely the fat. At the beginning I was a bit skeptic on this technique, because I was thinking the orbital fat is like the omentum. The more you remove, the more is the scarring. Here you can see completely naked the inferior rectus and the inferior oblique. Okay? But with a reduction, the first eye operated is the one on your left-hand side. And actually, this is the patient following the operation. The day after and the month after, she could elevate very well despite the large, presumably scarring tissue in the inferior orbit. When you want to obtain more result, more, let's say, effective decompression result, you can remove widely also from medial to the medial rectus and between the superior oblique and the superior rectus. In this case, you can reach up till 11 millimeters, like you can see here, and also reverse the convex, let's say the convex aspect of the periorbital soft tissue, as you can, repristinating the shape of the contour of the orbit and the eye. You can see here some other result. You can also play with the fat. You can simply, for instance, in a case like this, patient with a corneal transplantation in which we cannot really press too much to obtain a bony decompression, I decided to repristinate see, she has also some exophthalmos and some hypoglobus. I correct the whole thing by removing the fat in the superior medial compartment and redraping the fat of the lateral orbital inferior lateral orbital compartment under the eye. So removing the superior medial fat compartment and redraping the inferior lateral. This is the result, bringing back the eye at the same level as the other. So correction of exophthalmos and correction simultaneously of the hypoglobus. When there is remarkable exophthalmos, I think I still have a few minutes. When there is more exophthalmos, the lateral wall can be addressed. It can be valgus rotated, as you can see on the top. It can be completely removed, or it can be addressed into the deep portion. Or, in the case of a microorbitism, you can project anteriorly the lateral orbital wall with onlay implant to masquerade more than to treat the exophthalmos. Coronal decompression gives the most widely approach to the lateral orbital wall and avoid scarring at the level of the lateral canthus. With men with impaired baldness, the lateral wall can be addressed very easily through an upper skin crease or a lateral cantotomy cantholisis. You can see here through an upper skin crease with a decent result. You know, the eye on the right-hand side was the worst and was operated first. One day after surgery, the result could be this, as attractive as this. Coronal is still my favorite approach for patients that cannot be operated through a periocular incision, like this patient, or when there is a remarkable tension, like in this case, that lead to spontaneous orbital fracture, what I'm doing is a complete removal of the lateral orbital wall in a way till the dura, as you can see here, in a way to have sufficient space to enter the medial orbital wall and to decompress the orbital apex, as you can see here. I think I can close here. It's not necessary to go ahead. Last remarks, actually. Somebody is arguing that I am speaking against the new drugs for reduction of exophthalmos, just being an orbital surgeon, and for this reason having some conflict of interest. In reality, the new drugs are promoting us as orbital surgeons. Just my reasoning. If with the new drugs we can obtain 2 millimeters and the cost is in the order of 1,600,000 euro, our intervention leading to 10 millimeters reduction, or at least more or less something like this, has to be priced, mathematics is not an opinion, around 8 million euro. So maybe if you ask a little bit more when you are doing your decompression, probably you are justified. So the new drugs are very welcome because really promote our profession. Thank you very much. I think now I don't have the program with me. Thank you. I think it's Ganga. Okay. My good friend Gagandra Sundar Ganga is welcome to deliver his talk. Please, Ganga.
Thank you, Lelio. You should probably speak to my administrator so I can start charging more for my decompressions. I bring you greetings from Singapore, and people think I've come here to talk about mycophenolate. That's not really true. That's my multidisciplinary team, and I give credit to my senior resident over there who put together the data over here. And I'm proud to say that we're a member of UGOGO, despite the controversies that go with it. These are my declarations of conflicts of interest, but we now know that we don't make much money writing books. The real reason that I'm here is this plumber over there. How many of you can identify the cartoon character? So I'm here because of the Italian family and friends that I have. I call them the Italian connection. I don't want to call them the Italian mafia, right, Lelio? Yeah. So Giuseppe, thank you very much. Lelio, Luigi, and everybody else over here. But who introduced me to UGOGO as such in terms of the principles and concepts is Lelio. This is his meeting at PISA that he did, where we did a teaching course. But for the first time, we're bringing a teaching course over to Singapore, to that part of the world, where, as you know, 4 billion of the world population live. I welcome you all, not just for the thyroid eye disease session, but we're going to do an orbit oncology and thyroid eye disease as well. We all know about thyroid eye disease, how complex it is. It's important to realize that not all thyroid eye disease is Graves' orbitopathy. Graves' orbitopathy is a uniquely defined entity with its natural history, but thyroid eye disease can be associated with Hashimoto's or multinodal coitus, which does not follow the same national history. You can have a broad-based approach, or you can have a targeted approach. Andrea is going to talk a little bit about it. But the truth is, there's haves and have-nots. In other words, most parts of the world do not have the 1.4, 1.6 million drug. So you have to have solutions for them as well. We've been a UGOGO center since 2017, in that corner of the world itself. You have to work as multidisciplinary teams, and my multidisciplinary teams is not just endocrinologists, but immunologists as well, because this is an immunological disease. Yes, endocrine control is important, but it's an immunological disease. We have our own protocols to manage thyroid eye disease. You're familiar with various protocols. We have our own original NUH protocol, which has been published before on BGO, and our own modified NUH protocol, which is, I'm going to talk a little bit about it, a gram a day for 3 days, followed by a gram every month for the next 5 months. So you're basically drawing it over 6 months, rather than the standard 3-month protocol that UGOGO recommends. And of course, 2021 came up with the mycophenolate itself. We also showed that Asian thyroid eye disease is slightly different from what you read about in textbooks. That's why the atlases sometimes don't do a lot of justice. We have an entity called silent active disease, or the low caste disease, or the white eye disease, which again is a significant component. We talked about that yesterday itself. You also have to stratify your patients based on low risk factors and high risk factors. High risk factors are the ones who are likely to do much worse. And you probably have to start with a bigger bucket of water to put out the fire rather than just a cup of water at them as well. So the threshold and the dosage and duration also changes. Lelio talked about the caveman approach. Yes, I still do the caveman approach of orbital decompression. We are launching Artemis 2 at this point of time, which goes to moon and come back, and that's where the various targeted therapies, including teprotumumab, coming in. I don't have any conflicts of interest in any of these things as well. So of particular interest is mycophenolate, and I'm going to touch a little bit about it because this has been a little controversial drug. As you know, it made it to the first line therapy in the UGOGO 2021 protocol, but you also know there are a little bit of half science behind it, and people have tried it and either given up, or because of limited or lack of evidence, it's no longer typically considered the first line. And that's when we introduced it in our practice itself. Mycophenolate, again, is a broad-based approach like radiotherapy, like IV steroids, but not targeted approach itself. It still works and it's available in most parts of the world. So what we do different is not just the 500 or 750 milligrams a day. We go up to 1.5, sometimes even 2 grams a day, along the rule book of what immunologists do for the real immunologic diseases. So likewise, it's a combination of higher dose of corticosteroids and a higher dose of methylphenidate, not just a high dose, but a duration as well. The Mingo study talked about 6 months. We continue up to 12 months and slightly longer than that. And that's parallels the natural history of thyroid eye disease. So you're actually helping the patient along with a higher dose, longer duration, and not as an isolated agent, but along with intravenous methylprednisolone, much higher dose, again a longer duration of 6 months. And that's what it is. So we classified outcomes based on complete outcomes. They go to the pre-morbid normal, to partial outcomes where they're better, eyes are quieter, less proptosis, but still have evidence of thyroid eye disease, and of course the unsatisfactory ones, so the red, yellow, green, as you see as well. These are the dosages that we do in our practice. We started off with low dose. Yes, they kind of work, but you have this smoldering inflammation. I think Dr. Ilse talked about when you have inflammation, you want to hit them hard. When you have terrorism, you want to hit them hard. So you don't want to do low dose approaches itself and continue for up to a year itself. So these are the results that we have in our study. Number one, we compared it to the pre-2021 era of where we were using only IV methylprednisolone, or the milder low-risk disease where we're using only IV methylprednisolone. So it is not a prospective, not a randomized control study itself. Whereas the ones with the higher risk factor, the moderate to severe disease, or bordering on sight-threatening diseases where we use IV methylprednisolone, along with the mycophenolate that we see over here, we use for high-risk patients who are also smokers, either ex-smokers or continuing smokers who refuse to give up itself. This is the statistics that we have at this point of time. Most of our patients are young. We actually showed in our own data, half the patients actually are non-smokers and still have bad disease. So smoking is a risk factor, but it's not the only risk factor that we have in mind itself, and that's a stratification of ethnicity in our part of the world, and that's the reason why we're bringing in thyroid eye disease information to that part of the world. So this kind of shows the numbers of patients who had a complete recovery going back to pre-morbid normal, to partial recovery, which is about 25% of patients. And of course, patients who have progressed from severe disease to even sight-threatening disease, where you still have to take out your knife and your drill and so on and so forth. These are examples of patients who have good outcome, so which means that they have moderate disease to begin with, based on clinical activity score, based on the quality of life, which I think is the fourth question that we all should be answering when we're managing thyroid eye disease. These are other examples of patients who have pretty good outcome, where they go back to almost near normal, so they're back functioning as such. These are patients who have partial recovery, they're better, but still has significant evidence of thyroid eye disease, where the entire thing settles down, you have to put your knife on them if they decide to do so. And these are more patients who have persistent inflammation, they're better, they need something more, so you have to do adjuvant therapy with radiotherapy or something else. And more patients like that, these are patients who refuse to give up smoking. So when a patient is smoking and they refuse to give up or just cut down, it still is a problem. I think we talked about it in aesthetic surgery and functional surgery yesterday itself. And of course, there are patients who are bordering on severe disease or sight-threatening disease, because we now know the inflammation continues beyond your orbital decompression. That's a different controversy, we'll talk about it later, where they tip over or continue to progress what I call as persistent active disease, they develop compressive optic neuropathy, where you don't have a choice that after initial immunosuppression, optimizing general health for anesthesia and fitness for surgery, end up doing a traditional old-fashioned decompression. I'm a strong believer when patients have active progressive thyroid disease and sight-threatening disease, you need to continue immunosuppression for an extended period of time, anywhere up to 3 to 6 months after that itself. And of course, this is the patient who actually finally has good outcomes itself. So we showed that, number one, with IVMP alone, yes, most patients do better. These are low-risk patients, but still will require decompression, like Lelio kept pointing it out. You cannot hang up your knife. And that's what I was told when rituximab was introduced in the late 90s and said, no more decompression. Not true. I think we will still be doing decompressions. And of course, in the patients where we did the mycophenolate protocol, where the severe disease and thyroid disease, you still have to do a decompression, although there was one patient with sight-threatening disease with the combination of drug settled down enough that we did not have to do a decompression. That's what I call as medical decompression. Did we have complications? The answer is yes, right? But these are all mild transient diseases. That's why my team has not only an endocrinologist, but has an immunologist, has a hepatologist. We even have psychologists in our practice who hold the hand of patients, if you are not holding the hands of these patients itself. And a lot of these are transient. Even active viral hepatitis is no longer a contraindication, because with antiviral therapies, we are able to continue immunosuppression under the advice of a hepatologist, immunologist, and so on and so forth. So what are the strengths of the study? Number one, this is real-world data. These are patients we have. We have a consistent protocol that we've evolved over time itself. This is an Asian population in whom there's not much literature which is available. Limitation is a single center study, small sample size, it's non-randomized, so it has a limitation. So like everything else in the world, I think we now need to have real-world data, not just geographically, but ethnically, with the haves and the have-nots itself. So in conclusion, mycophenolate with corticosteroids, not just the standard protocol that's published in 2021. It does work, but you have to use higher doses and a longer duration of therapy itself. Still, in parts of the world where we do not have targeted therapy, it's not approved, it's not available, it's not affordable, there's still a role for broad-based approaches to management of thyroid disease. It works even better for mild, bordering on moderate disease. Doesn't quite work very well with severe and sight-threatening disease. It's still worth a try, because 1 in 4 patients does respond to this protocol itself. Thyroid disease, I think, is evolving beyond consensus statements. When people put a manuscript put down, these are just guidelines based on opinions and consensus and expert evidence. But that's where we experts come in, that we can choose to deviate from it, but it just provides a baseline around which you can start managing these patients itself. And I think where we community have to come together is to bridge the gap between haves and have-nots, so we don't have standardized state-of-the-art technology and state-of-the-art drugs, which most of the world cannot afford to. So with that, I invite you all to come to Singapore. We're going to have a 4-day meeting on thyroid oncology. Anything oculoplastics can do. We're going to have a lot of cutting-edge therapy itself. We're doing a teaching course. I invite you to Tallinn, Estonia, where Kadi Paluma is organizing a beautiful dacryology course. Please come in June. And I invite you to the top of the world, Kathmandu, where we're doing a 3-day meeting purely on ophthalmic trauma. Thank you very much.
Thank you, Ganga, for having respected the time, thing that I am not able to do, and to have pointed out that 2 drugs function much better than 1 drug alone. And why that? Because they block the chemotactic gradient at different level. More than 2 probably will even more function, but the problem is when we use too many drugs is toxicity. So that is the limitation of using more drugs. But still, nowadays, 2 drugs like mycophenolate and steroids are really something that is functioning. Thank you again. So it's now my pleasure and our privilege to have a talk delivered by Michael Kazim, that is somebody that doesn't need presentation in an oculoplastic and orbital environment. Michael is not here present, but he will give his talk by remote, rationalizing thyroid eye disease treatment in the current biologic era. Michael, please.
I'm unable to attend this wonderful meeting this year and reconnect with all of my good friends and make new ones. I'm particularly sad, however, this year, as I also need to pay tribute to a wonderful man, Daniel Weil. He was such a great person and a leader in the field of oculoplastic surgery and lacrimal surgery. He will be dearly missed by all, and in particular by me. I'd like to speak to you today about a rational approach to thyroid eye disease in this era of the new biologics. But before I begin to discuss the drugs, I'd like to review my thoughts on the natural history of this special disease. To begin with, it is, as we know, 100% self-limited. In a non-smoker, the disease lasts roughly 1 year. In a smoker, it extends to about 2 to 3 years. So any consideration of the treatment of the active phase of this disease has to recognize that we are chasing the natural history of the disease, meaning that by the end of this 1 year, medical intervention has little impact, whereas it has more impact early in this course. Spontaneous resolution is common, and we do not have very good predictors of the outcome of the disease on clinical or radiographic grounds. The disease is age-related. It breaks into a type 1 and type 2. On the left, we see a young woman with type 1 disease featuring a bit of proptosis and eyelid retraction, but none of the congestion featured in the central picture in a woman with typical type 2 disease. And then the second type of type 2 disease actually is in an even older person. This is an 80-year-old gentleman without any inflammation, but large muscles and compressive optic neuropathy. Here are two scans to show the two types. Type 1 on the left with proptosis, muscles are normal, and the fat is expanded, whereas the typical type 2, one gets large muscles, sparing the tendons, and the features of compressive neuropathy and motility dysfunction. Most of these cases are mild with lid retraction. Very few are severe on average. How it progresses can vary as well. This is a woman who progresses over a period of just 1 month. Slide left, slide right. Others progress more slowly. Spontaneous improvement, as I said, is a common feature. Here are 3 individuals with either mild or moderate disease, and absent any treatment, there is a substantial spontaneous improvement, and should be borne in mind when considering treating a broad swath of these patients. There are 2 general risk groups. The low risk group are typically young women, and they progress slowly. The high risk group are the ones we need to pay attention to. They're older, over 40 and certainly over 70. They typically are men, smokers, have sleep apnea, are diabetics, feature dermopathy. Their disease progresses rapidly, and there's early motility impairment. If one sees these features, then I would suggest that early treatment is most important. Secondly, I think there are 2 goals of treatment. We can either modulate the disease, i.e. suppress it. That's characterized by the use of corticosteroids. As long as the drug is given, the disease is put at bay, but as soon as it's withdrawn, the disease progresses back into its natural history. Alternatively, one can modify the disease, suspending its activity permanently, and there are agents that seem to have that benefit. Overall, we want to reverse the clinical features, prevent them from developing altogether if possible, and in so doing, reduce the need for surgical intervention. Rindel's curve shows the typical worsening, improving phase, and then stable. And during this process, without treatment, there is an aggregation of disease, features that are irreversible, like proptosis, lid retraction, motility impairment. If one uses a disease suppressor, say here, the disease will improve, but as soon as the drug is withdrawn, the disease comes back and runs its course. As an alternative, if one employs a disease modifier at this point, the disease stops, the Rundle's curve is shifted down and left, and the number of irreversible sequelae as a consequence are also limited. Through the efforts of dedicated researchers, we now see the possibility of any number of targets for this disease beyond the corticosteroids, which have dominated the field for more than 60 years. One sees the possibility of treating with Rituxan at the B cell level, IL-6 with tocilizumab, IGF-1 receptor with Tepro. They're on the horizon anti-TSH receptor antibodies. Radiotherapy works on the orbital fibroblasts phenotype. So we are now faced with a choice. Here's a laundry list of different options. How does one begin to make this choice? Well, I think we need to look at each of these drugs individually. There are very few excellent prospective randomized controlled level 2 data, but I would like to concentrate on methylprednisolone through the ICOS trials, the Tepro phase 2 and phase 3 trials, which are extremely well designed studies, the Rituxan trial coming out of Italy, our radiotherapy and corticosteroid combination trial, and the one performed by Peter Dolman, and some of the tocilizumab studies, which I think are important to consider, although they are also retrospective, because the data is starting to become very compelling. It is important in all of these studies to recognize that the patients were treated early in the course of their disease, less than 6 months of activity, because that's where the benefit can be accrued. The costs clearly are widely disparate, anywhere from some $4,000 for corticosteroids up to $400,000 US for the use of Tepro. The risks vary as well, and the ones of concern are well known for corticosteroids. Hearing loss is probably the most important for Tepro. Unfortunate cases of death have been associated with the use of rituximab. And tocilizumab has a small infection rate. So how do these drugs split as their effectiveness for modulation and modification? Well, modulation can be measured in any number of ways. Improvements in CAS, motility, and proptosis are some of the ways that one can do this. And in each of the cases, these agents have a good response rate to CAS, decreasing by approximately 3 points. Motility seems to improve almost equally, and proptosis improves between 1 and 3 millimeters across the board. As to modification, the most important feature is whether the disease reactivates after the drug is stopped. And we know well that corticosteroids are associated with a 30 to 40% relapse rate. We are now seeing that Tepro has a 30 to 50% relapse rate. But what distinguishes Rituxan radiotherapy, if used with corticosteroids, and tocilizumab is that the relapse rate is exceedingly low, suggesting that if used early in the right patients, one can certainly change the course of this disease. This also is associated with a lower rate of needed surgery. So I break these groups down into the low, medium, and high-risk patient groups. The lowest groups are the young-aged patients. They are slow to progress. They have primarily lid retraction and perhaps a bit of proptosis. For For them, we use the supportive measures called compresses, eye lubrications, elevations of the head. I would add a non-steroidal anti-inflammatory like diclofenac between 50 and 75 milligrams daily to reduce the inflammatory matrix and to improve their discomfort. And certainly insist upon abstinence from smoking and normalizing TSH and adding selenium in the selenium deplete environments. In the medium risk group, those are rapid to progress, have early diplopia and congestion. One does see the value in disease modulation. Again, earlier is better. One can either use the corticosteroid protocols of Ugogo, but I would, in all cases, add radiotherapy to reduce that relapse rate below the 40 to 50%, down to 5 to 10%. Tocilizumab has been shown to be effective, and I've personally found that it is now replacing my corticosteroid protocols for this group because it has a low relapse rate and a low side effect rate. Tepro, while effective, clearly in this group, has a relapse rate that is high, and there are groups that are now investigating the addition of radiotherapy to prevent relapse as we use in corticosteroids. In the high-risk compressive optic neuropathy group, treatment with corticosteroids to define whether the disease is reversible without surgery is, to my mind, important. Absent a response after 2 weeks of testing with corticosteroids, surgical decompression is appropriate. If the corticosteroids does begin to improve optic neuropathy, then a combination of the 12-week IV methylprednisolone protocol with radiotherapy or tocilizumab, 6 doses, is my current go-to treatment. Just to show you, because I have become very interested in the use of tocilizumab in these patients. Here's a particularly interesting case, complex. A 54-year-old woman with 5 months of thyroid eye disease, treated ineffectively with a Medrol dose pack, arrives with an intraocular pressure that's elevated despite 3 medications and laser trabeculoplasty. She is an insulin-dependent diabetic. She has been advised to take Tepro, which in all likelihood would be effective on her eyes, but the risks associated and her diabetes caused her to reject this option. She is, at the time that we first saw her, in evidence of compressive neuropathy more on the left than the right. She has significant ocular motility limitations, eye pressures in the mid-20s, and her talus in the mid-20s as well. Her CT scan is typical with enlarged rectus muscles and crowded orbital apex. She receives 3 doses of tocilizumab and shows complete resolution of her visual field deficits. Her tells improved just slightly, but her intraocular pressures are now below 20, and her ocular motility is improving. 2 months after her 6th dose of tocilizumab, her color vision has returned to normal. She has only a slight limitation of upgaze. Intraocular pressures are 15, and she is likely stable. 6 months after this, she continues to show no relapse, and her motility again is only slightly limited in upgaze. So here is she after 6 months post-TOCI number 6, and here is she before the disease. I think that is a remarkable response. In the stable phase, that is, to my mind, still a surgical disease. We have not seen a drug that has both the efficacy and the long-term durability to warrant its replacement of surgery. So have we actually achieved this targeted therapy? Well, I'm not quite sure we're there yet. There are a number of drugs still in testing that might also be valuable and they're worth watching for. I think we should ask for head-to-head superiority trials to determine the efficacy, safety, and the cost-effectiveness of these drugs, some of which, as I've mentioned, are extremely expensive. I think that we should focus more on the modification of this disease so that we can avoid the need for surgery. And these would ask the question of what is this post-treatment relapse rate? What is the change in the length of the disease? And what is the surgical rehab rate? Those are the measurements that we need to make. And finally, I think we should mirror the rheumatologist's approach, where they do look to stratify the disease and choose the appropriate drug for the appropriate indication at the appropriate time in the disease interval. So again, thank you for the opportunity to speak today, and I look forward to seeing you all at the next meeting.
We thank Professor Kazim for his very comprehensive talks, and now it is my pleasure to introduce Professor Gruber, Ashok Gruber, a good friend from India. To make this introduction, a few days ago I was looking through his extensive CV, and one thing struck me actually. I tried to pinpoint at least one society in India and Asia where he was not a founding member or a president. Actually, I couldn't find one. Professor Gruber will speak about how to deal with dysthyroid optic neuropathy from a surgical viewpoint. Please, Professor.
Thank you, lady. Thank you. Am I heard? Is it working? Yeah. Thank you, Lelio, for those very kind words. And it is great to be here. Thanks for your invitation and thanks to Yugi. We were all co-conspirators in the W. Soprus consensus statement along with Andrea, Augusto, Mike, and Tim. So we have been in that group for a long, long time, spending odd hours together, long hours together, and it's great to be together again for this session. So I'll be speaking on the surgical decompression for dysthyroid optic neuropathy. Earlier talks, including the one by Lelio, have made my task much easier. Why do we need orbital decompression? These include the sight-threatening conditions, of which dysthyroid optic neuropathy is the most common, but refractory glaucomas, in addition to corneal exposure, can be the other situations. Congestive changes with pain often are an indication. Globe subluxations Lelio spoke about, and aesthetic has become a very important indication for orbital decompression. But we'll be focusing on dysthyroid optic neuropathy today. The data suggests that this constitutes about 5 to 8% of all the cases of thyroid eye disease, bilateral in about 45%, with the risk factors being male sex, older age, diabetes, smoking, radioactive iodine therapy, amongst others. And we all know that myopathic or myogenic disease is more susceptible to developing dysthyroid optic neuropathy. Of all the etiological theories, optic nerve compression seems to be the most plausible explanation for dysthyroid optic neuropathy. Diagnosis is made with a history of blurred vision, color vision defects that are noted, afferent pupillary defects, and an important factor to be considered is what Ganga spoke about, that particularly in Asia, we may have patients without a high clinical activity score. Optic disc swelling, visual field defects, OCT, visual evoked potentials are all helpful in making the diagnosis. Imaging has a special role, and in MRI, diffusion weighted images and stir images may help us note the activity. And superior rectus and medial rectus thickening is particularly important because of anatomical reasons in predisposing to this thyroid optic neuropathy. Orbital apex crowding, where Barrett index can be helpful, has a reasonable sensitivity and specificity for prediction of dysthyroid optic neuropathy. Visual field changes, typically central or paracentral, often present late, having spread to include the peripheral field, including inferior and generalized defects. Coming to the management, this is what we looked at in the consensus statement of the World Society along with the International Thyroid Eye Disease Study Group. The role of IV methylprednisolone alone, corticosteroids combined with orbital radiotherapy and teprotumumab has been considered. We still await more corroboration for teprotumumab. However, if medical therapy fails, surgical is an important indication. And as we said, there is still a lot of thought that needs to be given about whether surgical intervention is probably the better way for most of the cases. Yugogo said that IVMP is the first option, surgery if inadequate response in 1 to 2 weeks. A study did not show any superiority of three-wall decompression over steroids, but it was a small study. Another study showed that almost 65% of the patients require a decompression in addition to IVMP, and combination treatments are probably more effective than single modalities. The decompression techniques for compressive optic neuropathy particularly will differ from those in stable thyroid eye disease. Here the emphasis shifts to medial wall decompression, inferomedial wall decompression, particularly the posterior orbital strut and palatine bone being targeted. Deep lateral wall will also increase the space available for the muscles, and fat decompression, as Lelio spoke about. The approaches to get to that decompression include the lid crease incision or the lateral canthotomy incision, transcaruncular approach, and the transphonacial approach. Additionally, endoscopic approaches and transcentral approaches are commonly used. As to the choice of the surgical technique, inferomedial approach was shown in a model to be most effective in decompressing the apex. The amount of reduction will vary depending on the walls that are decompressed. So in individual patients, there may be need for customization, as Lelio spoke about. The surgical techniques include the eyelid crease approach for the lacrimal keyholes, the so-called lacrimal keyhole, and the lateral wall decompression. So you dissect to get to the periosteum, and once you give the periosteal incision, you dissect the periosteum and the periorbita to expose the lacrimal fossa and the region of the deep lateral wall. You can extend the periosteal incision further laterally in order to do that. And then you can use a burr first to do a bit of trimming of the rim to increase the space available to you to work in. And then you can do an extensive decompression in the region of the lacrimal fossa if you so desire, or for the deep lateral wall, and you can get quite far very easily, and you're using a bit of water all the time in order to reduce the possibility of burns by the heat produced. The medial wall and the inferomedial are best approached through a transcaruncular or precaruncular approach and extended to the inferior pharyngeal conjunctiva. And this dissection with a blunt tenotomy scissors towards the posterior lacrimal crest helps us go safely behind the sac, expose the region of the medial orbital wall. Then you need to give a large incision. It's important to give a large incision in the periosteum on the medial wall. Dissect off the periosteum to expose the medial wall. And then remove the bone. The thin bole of the ethmoids can be removed by a bone blunt spatula, and then use of rongers to remove even more wall in the medial region, and then you can close it with a single suture of 80 white. For the inferomedial wall, you would expose you would incise the periosteum through the transconjunctival approach, dissect, lift up the periorbita, and target the inferomedial wall, focusing on decompressing the posterior-most part to reach the inferomedial strut in its posterior part, leaving the anterior part intact in order to have the least possible impact on the position of the globe and ocular motility, and to get to the palatine area. Fat decompression is again important, and most often it's important to get the intraconal fat out by dissection and then excise it as much as you want with the help of a cautery in order to reduce the possibility of a bleed. So being careful with the technique is important to avoid the orbital compartment syndrome. Let's now look at some of the illustrative clinical cases which highlight what this decompression does. So this was a 68 years old male with hyperthyroidism for 2 years, where diminution of vision was the predominant feature. It was operated earlier this year, January for left eye and March for the right eye. And this is the post-operative appearance with reduction in proptosis. And you can see the space created medially and inferomedially for the muscles, which has allowed the fields to improve very rapidly. And the left eye, where the fields were not recordable earlier, has now a visual acuity of 6x from 360 with an improvement of the field. And this is another example where the predominant effect after decompression, as you can see the impact on the floor and the medial wall, where the fields were predominantly affected without the visual acuity being affected. And 1 year post-op, you can see the significant improvement, almost a total reversal of the field effects. There was ESO and hypotropia, but over a 1 year period, this patient has adapted so well, she does not want a correction for this. This was a very active disease with a lot of edema, where predominant features were the edema of the disc and extensive superior limbic keratoconjunctivitis, and she responded well, and now 5 years later she is very comfortable with all the conditions having disappeared. Now, the complications of orbital decompression which need to be considered is worsening of diplopia and lid and canthal malpositions, with other risks being rare. However, lest we forget the benefits that the decompression causes, let's look at these two examples once more. This was a patient who was down to counting finger close to face in both the eyes with secondary optic atrophy, but over the next 4 years has improved to 612 and 69 with a pale disc, with congestive disease having disappeared. And this was a patient who had so much pain that he had suicidal tendencies and a refractory glaucoma. He often said he wanted to commit a suicide, and after his treatment, he's a beaming young man again. So there are many, many reasons to never lose hope in this thyroid optic neuropathy, and we have the tools to get our patients to a much better clinical condition and much happier state of life. Thank you.
Thank you, Ashok, for your comprehensive talk and for having mentioned our efforts in the consensus paper for the WSO-PRS. We had that idea, but if we didn't have this lady here, this colleague, that was the motor, really the engine, we will never be able to finish anything. Actually, I must confess that Professor Andrea Kösler is really one of the column of Stanford University and has been super supportive for our activity in that consensus. And as you can see, she is so proactive in everything. She's already here. So please, Andrea, it's yours.
Thank you so much, Lelio, and thank you so much for the invitation. I've had such a lovely weekend and look forward to another couple wonderful days. So I'm Andrea Kostler, Director of Oculoplastics at Stanford, and I'm going to be talking about teprotumumab. I want to disclose that I am a consultant for Amgen and most of the pharmaceutical companies that are investigating drugs for thyroid eye disease, which is relevant to this talk. So teprotumumab was approved in the United States in 2020. And since then has been approved in Brazil, Japan, Saudi Arabia, United Kingdom, Switzerland, and the European Union. And so if you do not have access to teprotumumab, the chances are that you will have access to either teprotumumab or a similar IGF-1 monoclonal antibody in the near future. So let's talk about how this drug has really changed the way that we think about thyroid eye disease, but also what we expect out of our treatments. This drug has really changed our expectation of treating this disease. Now, I always learn the most from my patients, so I'm just going to introduce you to a couple of my patients so we can all learn together. This is the very first patient that I treated with teprotumumab. In fact, he's the first patient to be treated after the drug was approved in January of 2020 in the United States. So he's a 45-year-old male. He presented to me with thyroid eye disease. He had inflammation, proptosis, restrictive strabismus. He had been treated by an outside institution with IV methylprednisolone for 6 doses, and he had received radiation. But unfortunately, he had a myocardial infarction. He had to stop his methylprednisolone, and this all happened when his left eye became active. But he came to me when his right eye became active, and you can see that his right eye is stuck underneath his right upper lid, and his left eye is stuck underneath his left lower lid. He's functionally blind. He cannot see, he cannot function. And he had vision of 20/50 on the right, 2100 on the left, a relative apparent pupillary defect, and basically imaging and visual field test shows us that he presented to me with this thyroid optic neuropathy. So teprotumumab was approved in January of 2020, and this patient is an engineer like many of my Silicon Valley patients, and so I want you to listen to his experience after the first day of teprotumumab.
I feel changes the first night after treatment, to be honest. Every night I take a picture and I can see the gradual change of my face, especially my right eye.
You can see that he covers his left eye because it was so cosmetically and functionally unacceptable. He took a picture every single night, and what he said was that he noticed improvement on the first day. You can see from the first to the second dose, from first to second dose, you can see that his right eye goes from being stuck underneath his upper lid to moving into primary gaze. He can now function, he can now drive, and he can even be recognized by his iPhone to open it up. And so it really did change his life, and so that after the 8 infusions, he had a reversal of his dysthyroid optic neuropathy. His proptosis and his strabismus improved on the right side. His left side did not really respond at all, and so we did decompression and strabismus surgery, and he's 20/20, and he's doing great. So 4 years later, this is his video.
That really changed my life, to be honest. Of course, kind of 3 years, so you kind of get used to that. You kind of expect the worst. But getting it back is just, you feel like when you first learn how to ride bikes, then you just want to go out and ride every day. Like those first few days, just like that. You just want to go out and see the world because now you don't need to cover your eyes. You feel normal.
So he feels normal. He says that it changed his life. So people always ask me, why do you treat with teprotumumab? Well, it's for patients like that and many others. So before and after teprotumumab. Before and after teprotumumab. Before and after teprotumumab. And another before and after teprotumumab. So, there's no doubt that teprotumumab can be effective in the properly selected patient. But of course, our patients continue to teach us every day, and this is the 5th patient that I treated with teprotumumab in June of 2020. So she's a 65-year-old female. She's got prediabetes, Graves' disease. She was treated with radioactive iodine ×2. She presents to me with active, moderate to severe thyroid eye disease, most worried because she was having worsening double vision for about the first 8 weeks before she came to see me. You can see from these photos, she has pretibial myxedema, high TSI, 5 on her CAS score. She has proptosis worse on the right than the left. She has restriction to upgaze on the left. And so I treated her with teprotumumab. This was June of 2020, and she does great. Her pain is gone. She is so happy. And I notice that she's kind of not really hearing me properly in the clinic, and she tells me that her ears have been plugged and she feels like she's on a plane, but it's not a big deal because if she just swallows or moves her ears, that she can get rid of the sensation. And so, this is June of 2020. I didn't really know what to do with this, so we took her to ENT and we got a patulous eustachian tube test, which showed that she had a patulous eustachian tube, which now I know all about, but at the time I knew nothing about a patulous eustachian tube. And so with ENT, we got an audiogram and we were trying to decide what to do. We knew from the clinical trials that there was this nebulous discussion about hearing loss. So we checked an audiogram and she had some hearing loss on her audiogram, but we didn't know if this was baseline, worse than her baseline. We didn't have a baseline test for her. She swears she's had no change in her hearing. She does not want to stop the drug. She wants to continue the drug. So with ENT, we decided to check monthly audiograms for her. And we did, and it wasn't until 2 additional audiograms were done where we found some hearing loss in 8,000 hertz, which is like something we don't even hear. It's not the frequency that we use regularly, but we found that decrease in her hearing, and we also checked a word recognition score. And we found that her word recognition score went from 100 to 88%, so she's not recognizing all words. And so this was the very first patient to really teach me about hearing loss, and she's the reason why we wrote the paper about hearing loss that was published in the AJO in 2020.
My experience is actually when you get on the plane, your ears will be all clogged up, and when you swallow, it clears a little bit. Then I realized when people talk, I cannot hear. But I thought that was still related to the clogging. I did not relate that with a nerve damage.
Multiple.
Okay, then I'll hear multiple.
So you're missing the first syllable
Yes.
of the word.
Multiple.
Like fast?
Say, for example, you just say talking. I cannot hear the T, but I know what you're saying.
Mm-hmm.
Another social problem is when you go to a restaurant and you sit at a big table. It's impossible to hear anybody. There's no syllabus. I cannot understand.
Mm-hmm. So what do you do in those situations?
I just explain to people that I cannot hear.
So this patient again taught me so much about hearing loss, and this is a video of her 3 years after she finished her teprotumumab. So, we see that this drug works, but we also see that it is powerful in good ways and in bad. And so I'm going to talk a little bit about the short-term efficacy results of teprotumumab in active, chronic, and stable thyroid eye disease patients, and then what's really important is the long-term efficacy of this drug. So when we think about treating thyroid eye disease, we all know that we need to think about the activity and the severity of the disease, but I think we also need to think about the main ophthalmic manifestation of the disease, and then also contraindications and risks to the treatment, super important when we're selecting drugs. So does this drug work? Does teprotumumab work for active, moderate to severe thyroid eye disease patients? Yes, it does. The clinical trials have shown us that very clearly. Significant improvements in proptosis score, diplopia score, inflammation, overall score. We've all seen these results before. Should we treat every single patient with moderate to severe thyroid eye disease? No, we should not. So you really need to think about the main ophthalmic manifestation. If patients are presenting with inflammatory signs and symptoms only, well then treat them with an anti-inflammatory, IV steroids, tocilizumab. But if they have a contraindication to IV steroids, well then yes, you're going to bring in those biologics, including teprotumumab, as an option. When patients present with diplopia, severe diplopia or proptosis as their main manifestation, well, teprotumumab does have superior efficacy to the other treatment options that we have out there, so it is something that can be considered. However, if they have a contraindication, if they don't have access, and for the many other reasons why we don't treat with teprotumumab, we have other treatment options out there. IV steroids with radiation, tocilizumab, that's all been discussed already. And so this is an algorithm that was published by my team in the Journal of Clinical Endocrinology and Metabolism, and it's just one way of thinking about how to customize our treatment for thyroid eye disease. What about chronic, moderate to severe thyroid eye disease? Does duration matter? I think we all know that the earlier you treat these patients, the better, but there was a clinical trial called the OPTIC-X study that showed that patients that had an average disease of 12 months or more had the exact same response to treatment as those that had disease of 6 months on average. And so what this study demonstrated, and many other studies have since then, is that it's not really the duration of the disease that matters. Instead, it's really just the progression of the disease that matters. And so yes, it's better to treat patients earlier in the course of the disease, but really it's the progression and the severity that matters, not the actual time point that you intervene, but earlier is better. How about for stable or non-inflammatory or low CAS or whatever you want to call stable thyroid eye disease? Does it work? Well, the studies are it's a little bit hard to discern. There was a phase 4 study that looked at low CAS patients. They had have a CAS score of 1 or less to be included in the study, and they also had long duration disease. And what they showed was that there was an absolute proptosis reduction of about 1.5 millimeters at week 24. So 62% of patients had that magic 2 millimeters of proptosis reduction or more, whereas 25% in the placebo group did. So there was a significant response to proptosis reduction, but there was not a significant improvement in quality of life or in diplopia responder rate. So does it work for, stable disease? I'm not convinced, but I'll let you interpret the study for yourself. 1.5 millimeters of proptosis reduction, 62% of patients had 2 millimeters or more, and there are no long-term studies, so we don't know if this result is lasting. So what about the long-term efficacy of teprotumumab? Well, this is where it gets interesting. So in the Kahali study that was published in the Lancet, where he took a look at the patients from the phase 2 and 3 clinical trials, and they followed these patients 51 weeks after treatment, what they found in the clinical trial setting was that of the patients that were followed for 51 weeks, that about 67 and 69% maintained their proptosis or diplopia response, which means that in this clinical trial study, of the patients that continued in the study, 33% had regression at about a year after therapy. Well, these studies have been replicated after approval. So the Cleveland Clinic group showed that in 21 patients that were treated, about 60% had reactivation or regression with about a year of follow-up. And then the Harvard group with Suzanne Freitag, they looked at 119 patients and also found about 60% of patients, 65%, had regression at about 11 months follow-up. And so what we're seeing is that, no, the results don't last in all patients. We did a study where we did this national database study, and we were basically trying to look at teprotumumab versus IV methylprednisolone because there are no head-to-head trials yet. And so we looked at about 300 patients that were treated with IV methylprednisolone, the Kahali protocol, and about 400 patients that were treated with teprotumumab, and we followed them for about 18 months, and this is a database study. And so we looked at things like the need for additional treatments and treatment complexity after treatment and treatment burden. This was published in Thyroid Journal. And so what we found was interesting. So this is a starburst plot, and so what this shows is each of the rings after the center of the treatment, which is IV methylprednisolone, represents another cycle of treatment. And so green is showing you more steroids, orange would be teprotumumab, purple would be surgery, and then blue is a variety of other treatments and targeted targeted therapies. So in the IV methylprednisolone treated group, about 50% of patients needed an additional cycle of intervention, and about 33% needed at least 3 or more additional interventions. And you can just look at their treatment journey. I mean, you can just see, like, this is what they go through. And this is 2 years follow-up, because it's 18 months after being treated, and we had like a 6-month, we started following their post-treatment course after 6 months. Now, when you look at the teprotumumab group, about 43% needed a second round of treatment. And orange is teprotumumab, purple is surgery. And so they also needed another round of treatment, and in most cases it was teprotumumab. But you can see that they didn't need that many more rounds of treatment. So this is, the 2 treatment journeys of our patients. Look at them for yourself. Which patient would you want to be? So, in conclusion, teprotumumab is effective in the short term for active and chronic, moderate to severe thyroid eye disease. I think the results are a little bit less convincing for stable thyroid eye disease, but I'll let you make your own decision. However, regressions and reactivations do occur. It is a fact. 33 to 65% of patients are going to have a reactivation or a regression, most commonly regressions, if you follow them for a year or more. 40% of patients are going to need a second round of treatment of either teprotumumab or surgery or something else. When you look at the comparison between IV methylprednisolone and teprotumumab, you can see that the treatment journey is more complex and there's more burden in the IV methylprednisolone group. However, do I still treat with teprotumumab? I do. But I do not think that one drug should be able to treat a disease that can be chronic forever, indefinitely, right? If you treat for 6 months, you shouldn't think that it's somehow going to, it's not a modifier, as Michael Kasem said. So does it work for all patients and does it last? No, it doesn't. We have other treatment options. And so we have to really put on our thyroid eye disease hat and think about what's the best treatment for these patients. We want to customize our treatment. And yes, combined therapies are really important. We are now treating patients with radiation and teprotumumab, sometimes tocilizumab and radiation. You really need to think about your patient, their risk factors, their activity, the severity, their main manifestation, the phenotype of their disease. There are so many things that we need to consider. We need to understand that many of our patients are going to need retreatment, so you just need to educate them at the beginning when you start talking to them about this disease journey. And surgery is still very, very common. I do surgery very, very commonly in my patients, so surgical rehabilitation is oftentimes necessary. I just want to thank you. Oh, couple more questions. So, I don't think the question is, does teprotumumab work? It does work. You just need to know when to apply it. And really, not every patient needs to be treated with teprotumumab. I think we all know that. But what we need to understand is who is regressing, who is reactivating, how do we treat these patients, and how can we combine therapies so that we can improve efficacy and durability. And with that, I want to thank you all for your attention. I've had such a lovely weekend, having so much fun with new and old friends. Thank you so much.
Thank you, Andrea. I think we spare 5 minutes for question, and I will start from the panel, actually. And lady first, Ilse, please. If you have question, is the right one.
Well, I have several questions, but I would like particularly to comment on Ashok Grove, your beautiful lecture. I particularly like your approach to the medial orbital wall, the pre-caruncle. It's less well known. It has been developed in 2003 by an ENT surgeon, Chris Moe. He was particularly using this approach to go for a transorbital approach to the cranial fossa. But it is a beautiful approach. It doesn't bleed. The edge where the skin stops and the conjunctiva starts, pre-caruncle, you cut, you dissect, and it's without blood, you're immediately on the medial orbital wall. So I really appreciate your efforts to introduce this technique also to this audience. Then I have another question, which is more actually overwhelming all looking all the presentations today. It's all about what is the definition of a relapse, a recurrence, recalcitrant disease, in Graves, So it's all about the natural history of the disease, and indeed about the timing and the duration of the treatment, as you nicely presented, but we still need to think of the natural course of disease, the Rundle's curve, and indeed all the treatment that we so-called consider not efficient is just probably like in myositis, an improper treatment, and it's nothing to do with the drug efficacy, but rather of the physician who has actually misjudged the patient's course of the disease. But this is just a philosophical, more widespread thought.
Thank you. Augusto, do you have any question?
No, different observation.
Please.
Lélio, I really enjoyed your Lélio Kumab and Augusto Kumab. Nice concept.
Okay. Please, Dr. Tenuta.
Thank you for this presentation. It's very precious. For Professor Baldeschi, what is the relapse rate after surgery?
No, it's a good question. Theoretically,
I am no surgeon, I am a physician.
Okay. Well, theoretically, there should be no recurrence because the condition sine qua non to operate is a stable disease unless we don't operate during the active phase for this thyroid optic neuropathy. Despite this premise, there is one paper, and I was the author, published I think 2006 in Ophthalmology, where 3 cases of recurrence in stable disease out of 249 decompression done. So it means 1.3%. And actually, that is immunologist and microbiologist. And apparently, all 3 patients, this was not published, have multi-resistant Staphylococcus aureus in the nose. So the lipopolysaccharide is one of the possible cytokine-acting like substance that can activate the chemiotactic gradient of the T helper and the macrophage at intermediate level. Excuse me. I was saying that the 1.3% reactivation was, after the publication of the paper, linked to the presence of multi-resistant Staphylococcus aureus in the nose. That was an observation of my wife. She is a microbiologist and an immunologist. What was happening in Pisa? We had the first 5 cases of liver transplantation that passed away. After having had this situation, my wife was asked to check if these patients were different from other patients operated elsewhere, and she discovered that all these patients had multi-resistant Staphylococcus aureus in the nose. From that moment, they started treating with gel of chlorhexidine in the nose the patient before liver transplantation, and they have no that anymore. At that point, we got the idea that maybe the same bacteria could have been involved into the reactivation. Once we do decompression, all of the reactivated cases were decompressed through an inframedial decompression. So we checked, and apparently all of them were positive for multi-resistant Staphylococcus aureus, and then all of them had the lipopolysaccharide in the nose. And the lipopolysaccharide of the capsid of the bacteria is one of the possibility to activate the chemiotactic gradient, leading either to deposition of glucosaminoglycans or to, let's say, fibroblast activation.
The second question is about Professor Kozlet. Have you liquid biomarkers to evaluate the inflammation in a strategy for therapy?
Thank you for the question. Actually, at Stanford, we do have a biorepository, and we have actually submitted a paper for publication where we will routinely grab tears from the patients before, during, and after teprotumumab treatment. So we have a series of patients where we checked their tears before, during, and after teprotumumab therapy, and it's really interesting what we found. You know, you can check tears and check a protein profile of a patient to understand the proteome of the disease, and we feel like we have found a few proteins that could predict patients that are going to have recurrence or regression after treatment. There were 2 patients that had reactivation, and they kind of, their protein profiles kind of huddled together. So, you know, I'm not a proteomics expert, but it's very preliminary work, and I do think that things like tear films and other types of liquid biopsies can help us to better understand this disease, but I certainly don't think that we're there yet.
Last questions for Professor Sandler. The mycophenolate is a slow reaction. Do you think, have you experienced by rituximab for these patients? Thank you so much.
Our own limited experience from several years ago when it came out, when we tried it on an ad hoc group of patients, it was a hit and a miss. In fact, we had missed more patients than it hit more patients. So after knowing about the toxicity, and at that time, initially it was quite expensive at that point of time, our immunologists and endocrinologists have stopped using it and have stopped using it as well. And to reiterate the point about tocilizumab again, that has now emerging as a second-line treatment at this point of time. So I think that's probably the way we are headed in terms of targeted agents. I do have a question and comment for the entire crowd as such. So Andrea in particular, since you have the most experience, at least in this crowd with teprotumumab, are you able to forget the proteomics? Are you able to look at a patient now, phenotype, whatever you want to call it, or the symptom or the sign, to say that this patient is likely to benefit from tepro versus not likely to benefit? Or do you just try it and hope for the best, number one? Number two is, if you take a leaf out of the book of immunology, rheumatoid arthritis, for example, with aggressive treatment nowadays, the surgical rehabilitation of rheumatoid arthritis patients has gone really way down. And here you and I and Lelio and Ashok are all still talking about decompression. It looks like we are far, far away from really unraveling the mystery of thyroid eye disease. Insights.
Thank you so much for the question. I wish that I could predict who responds best to teprotumumab. I certainly cannot. But there are a lot of things that we can do to help us to understand who might respond well. So Don Kakawa and his group at UCSD published a really nice paper, and Suzanne Freitag published a separate paper with similar ideas that patients that have more muscle proliferative disease, they do seem to respond much better to teprotumumab. However, they also seem to be the ones that regress more. And so I think that when you have a patient that has a lot of soft tissue expansion, very, very large muscles, and very severe disease. We have other drugs that can treat patients that have more of the mild, moderate disease. I think if they are acute, progressive, they can respond, but that doesn't mean that I treat everybody with teprotumumab. I'm actually treating with teprotumumab less and less and less, the more and more I learn about the drug and the other treatment options out there. I also am treating with tocilizumab a lot as well. As far as surgeries, I still do a lot of surgery, but I've had to change my game for surgery. You know, you saw my before and afters with the teprotumumab. Teprotumumab does not make them look like they're pre-disease state. You know, that's certainly not the case in most patients. And so I'm still performing a lot of surgery, but there's a lot of an aesthetic outcome aspect to the surgeries. So yes, I'm doing a decompression, but I'm thinking about really customizing this decompression to the patient, you know, repositioning the lacrimal gland, fixing the Charlie Brown sign, you know, taking down some rim if I want to improve the retraction, you know, all the things that we know that we want to do to try to make the patients look and feel like they did before the disease state. So I'm still doing a lot of surgery, but I do think that if you were to look at national trends, because studies have been done, the number of decompressions has gone down since teprotumumab was released. And that data is a little bit fuzzy because of how it overlapped with COVID, but still it does seem like decompressions have gone down to some degree.
Thank you, Andrea. I think there is still room for 2 free questions. I saw a young colleague there, maybe. Okay. Please go ahead with your announcement and then we go for...
We have some important announcements for today. Our afternoon session is going to start at 1:45. That's 15 minutes before 2 o'clock. Dr. Vera Ismail is going to give us some presentation that she could not, unfortunately, give on the conventional on Thursday. Then at 6 o'clock, we're going to have the Best Poster Award. That's an award for the best poster. And right after that, we're going to have a cocktail reception and then a pasta party at the Grand Hotel. You are all very welcome to attend everything I mentioned. La sezione pomeridiana inizierà alle 13:45. Alle 18 si terrà la premiazione per i migliori poster, seguita di un cocktail e di una pasta party. Thank you very much.
Thank you. So speaking about the medial wall approach, it becomes much more easy if you have much greater space, having done the lateral wall before, the deep lateral wall decompression. That makes it much more easy to approach the medial wall. And I believe it's fine to do multiple approaches at the same time, especially lateral and medial, because the cases often present very late to us. And either way, we increase the space there, we are helping them a lot. The kind of help that we are able to give them justifies the occasional diplopia, and they tolerate it very well, the new induced diplopia that we may get with inframedial and medial wall decompression.
Thank you. There is any other question from the ground? Then, Ganga, please.
So I know you'll say feels left out. You feel left out in this thyroid session. We need to involve you as well. So the question is for you and the thyroid experts in the crowd. We are talking about systemic therapies practically at this point of time. How many of us are treating through intraorbital injections for thyroid disease? Just a show of hands. There? Not very many. Same question for you, for myositis. We are talking about steroids, oral steroids, intravenous methylprednisolone. What proportion of your patients' unilateral disease are you treating with intraorbital steroids? Along the same lines of thyroid, unilateral thyroid disease.
Thank you very much. No,
Spaghetti are waiting, yeah?
Sorry?
Spaghetti are waiting, please.
No, because there's always the issue that you can have an injury to, that you can actually. We don't do any local neither rituximab even. Okay, thank you.
Are you talking for unilateral disease, myositis, or unilateral thyroid disease? Either steroids alone or steroids in combination of both. That's one for both patients, minimizing the risk of systemic toxicity. So that's the reason why I was asking. Lelio, your thoughts?
No, it was clear. So thank you again for all the speakers, the panelists, for the interesting discussion. I think now we can go, all of us, to decompress a good plate of spaghetti, please.